Participant, and welcome to the National Distance Learning Seminar Series. Today's topic is Programmatic Update in ART and Frequently Asked Questions from the Field. It is our honor to have Dr. B.B. Rewari with us to deliver a session on Programmatic Update in ART and Frequently Asked Questions from the Field. Dr. B.B. Rewari is an Associate Professor of Medicine at PGI-MER Dr. RML Hospital, New Delhi. Presently, he is on deputation to WHO Country Office for India as NPO ART. He has been involved with National ART program right from the stage of inception in 2004 and its implementation till date. He has undergone training on HIV clinical management in Thailand, USA, and Japan. He also received a Fogarty Fellowship on HIV at Johns Hopkins University at Baltimore, USA. He is a national level trainer and has been involved with NACO trainings since 1999. He was a member of Guidelines Core Committee for WHO 2010 ART Guideline and is a member of HIV-TB Core Group at STOP Department at WHO Headquarters, Geneva. He was also member of 2013 WHO ART Guideline Development Group. He is a member secretary of NACO Technical Resource Group on ART and heads the National AIDS Clinical Expert Panel. He was an editor of an index journal for 6 years and has edited a book, HIV/AIDS Clinician Perspective. He has over 100 publications to his credit and is involved with number of research projects with ICMR, UCLA, and Brown University, USA. He is a recipient of Best Teacher Award from DMA, Best Allopathic Physician Award, G.B. Jain Oration, Ranbaxy Oration from IMA, and P.J. Mehta Oration 2013 by the Association of Physicians of India. He was awarded Fellowship of Royal College of Physicians, Ireland in 2010. Thank you, sir, for taking this NDLS session. Please take over the session.
Good afternoon, everyone. A very warm welcome to this session and thanks for your participation. At the outset, I would like to say that there was a great response when I sent out email to all ART centers to send questions. We got almost 200 questions to which answers were required, and some of these were duplicate, but after sorting out, we were able to sort out almost 60 to 70 questions, of which I have included 30 questions in this session. This is a long session and we may be able to complete it today or not. If not, then we'll be continuing on 22nd of July with the remaining questions in this session and maybe more questions by the time we get on this. This presentation will be slightly different from one you are having in NDLS, wherein you ask questions and we try to respond in between the question by typing in the box to your queries. Slightly different because we already have the questions, and if you have queries pertaining to those questions which are being discussed, I would like to take those questions in between. If there are different queries which don't pertain to that particular slide or that particular question, then we will take it up in the next session. You can email them or you can type them here also. We will compile them from this session. So basically, the objective of this session was just to have a refresher on the National ART PPDCT guidelines, for which there were trainings held in months starting from November till February. There were trainings all over the country and almost 470 medical officers were trained in these trainings. So I will be just taking up key presentations from those 2 days refresher training just to remind you again. I will also be giving you some update from the recent studies which have come up after the November 2014. We'll also try to give some guidance on common scenarios that we see in the field, answer common queries from the field, and we'll have interaction on technical and programmatic issues also. But all these will be summarized in form of a document and will be sent to all centers after the session in form of a document in addition to the recorded link that you basically get from ITech. What I have tried to do is basically of all the queries that we received from the field and I have been getting on NESEP also, basically I have tried to sum them into simpler queries which most people should know. Some of these could be very simple for those people who have been in the program for many years, but there are new ART centers which have opened up in last 1 year, and in the last 40 centers which opened up after the refresher training, they have not been adequately trained or they have not undergone the 12-day training because of financial reasons. So some of these questions may be very simple, but these are just refresher, and we have some questions which are slightly difficult, and we will have more questions in the next session also on 22nd July remaining from the which I got and those we will get in this. Basically, just to remind you that India has got world's second largest ART program with almost 870,000, 8.7 lakh people on ART at 510 ART centers and over 1,000 link ART centers. So there are almost 15,000 facilities which provide treatment to 8.7 lakh people currently alive on ART. If you see the evolution of ART guidelines, the guidelines have been changing ever since 2002, 3, 2006, 10 and then again in 2013. Basically the focus of these guidelines of WHO which country adopts has been that we should start ART early. Initially it was at 200 should be the cutoff CD4 count to start ART, and then we thought it is better to start at 350, and then the evidence became available that yes, we should start at 350 and then 500, and you are aware of these guidelines. But focus has also been on simplified treatment options for pregnant women, on simpler treatment, giving fewer options because we follow a public health approach and there should not be too many confusion in the field, and guidelines should be set that these can be actually rolled out at a facility which is nearer to patient residence. We have gone now from medical college to district hospital to sub-district hospital and some of the area hospitals and some CHC in high prevalence states, but basically aim is to go down further so that patient does not have to travel large distance. So the focus is on regimen which are safe, which are more robust. More robust mean thereby the development of resistance is delayed, and we are moving towards better monitoring of the patient already started on ART. So summary recommendation of 2013 WHO guideline, they recommended that ART should be initiated early when the CD4 count is equal to or less than 500. It was also recommended to have a single preferred first line regimen, a fixed dose combination of tenofovir, lamivudine, efavirenz. It also recommended lifelong ART for pregnant and breastfeeding women, immediate ART for all children less than 5 years, move to viral load monitoring, integration of ART into other services like TB services, like MCH services, decentralization which we attempted to link centers, task shifting maybe to nurse, and adherence support. So let us see what were the 2014 recommendations. Basically the guidelines very clearly said that for all HIV infected adult and adolescents with clinical stage 1 and 2, it should be started if ART is less than 350. This is NACO guideline which is likely to be revised to 500, and I know there will be immediate question that we are saying this is going to be revised, but yes, it has been delayed because of issues related to procurement, and there was some reduction in the funding which now is being discussed, and this 500 cutoff will be in place soon. But as was earlier for clinical stage 3 and 4, ART is to be started regardless of CD4 count. All patients with HIV and TB co-infection, whether this is pulmonary or extrapulmonary, ART is to be started regardless of CD4 count and the type of tuberculosis. ATT to be started first and ART to be initiated as early as possible within 2 weeks to 2 months. Similarly, for hepatitis B and C co-infected patient, all those patients which have evidence of severe chronic liver disease, ART to be started irrespective of CD4 count. Again, why the guidelines change and how are these guidelines being changed? 200 cutoff for initiation of ART is history. Long back it was in 2004 when we started until 2008 or 9 when we moved to 350, and now the guidelines are to move to 500. But let us see quickly into the background why these guidelines are changing. If you see this 200 is very clear that 200 was taken as a cutoff because most of the life-threatening opportunistic infections which could be fatal occur when the CD4 count is less than 250, and all you know that this includes PCP, toxoplasmosis, cryptococcal meningitis, MAC, CMV. So 200 was taken as optimal cutoff basically to start ART. Then came 350. Why? This came evidence from a study called CIPRA ST001, which you very well know. It's also called as HIT trial, whereby patients were randomized 816 patients to two groups to start early ART within 2 weeks of enrollment or standard of care when CD4 count is less than 200. The median CD4 count at study was similar in both the groups, and primary endpoint was survival. And basically, if you see in this study, when ART was deferred, there was when ART was started early, there was 75% reduction in rate of death and 50% decrease in incidence of tuberculosis. Since this was a randomized controlled trial, this was a very strong level of evidence to change from 200 to 350. Again, in 2013, WHO came with guideline that it goes to cutoff of 500. This is not arbitrary. Again, this was based on two studies. One is published by Cohen et al. In 2011, which was a summary of a trial called HPTN052, and there was another trial called SMART trial, which was published in 2008. And both these studies again show that there is a lower risk of progression to AIDS or death, and they also showed that there are other studies, observational studies, 13 studies, which show that there is a lower risk of death if you start ART early, and there is a lower risk of progression to AIDS in 9 studies if you start ART early. So the point was moved to 500. Now there are other trials which have become available. These have not been discussed so far in the technical resource group of NACO, but these studies are available, and one is the African Temprano trial, which very clearly showed after 7 years of randomization of patient between CD4 less than 500 and more than 500, that starting treatment at CD4 count above 500 reduces the risk of serious illness and death by 44%, and this is published by Daniel C. et al. In the recent CROI conference in 2015. This study also found a 6-month course of INH preventive therapy reduced the risk of developing TB by 35%, and this is in addition to early initiation of ART. Basically, if you look at this, IPT should also be rolled out in the program, and I will also come to you this in the presentations little later. But what changed the scenario recently was the START trial. START trial was basically strategic timing of antiretroviral treatment, which was done at 215 sites in 35 countries, whereby more than 4,600 patients were actually enrolled. And there were 2 sites in India itself in the START trial. It was seen that there is a reduction of 53% in risk of developing serious illness or death, basically if you start ART even at CD4 the 500. And the data safety board actually recommended that treatment should be offered to all participants even in the deferred group, because we are not giving the benefit of early treatment to those people, and this will not be ethical. So based on this START trial, let us see what the experts said. You know, Anthony Fauci has been a guiding force in HIV AIDS. He is the director of National Institute of Allergy and Immunological Diseases. He very clearly said that we now have clear-cut proof that it is of significantly greater benefit to an HIV infected person to start ART sooner rather than later. Moreover, early therapy also conveys a double benefit. You know from PMTCT that if the viral load of the pregnant woman is reduced, then transmission to child can be almost eliminated. So taking a similar analogy, basically by reducing the viral load of the patient, there is a reduction in the community viral load and there is a reduction in transmission of HIV. So if we have to reach our goal of 0 new infection, which is 3 zeros of UN AIDS, basically it is very important that we start initiation of ART very early. Having said that, these are the newer things, but we have to remember the national guidelines. We have to remember that we are still at 350. Yes, we are at 350. Now, when I pose question to you, I would expect you to think that this is true or not. When I say expect for, immediately you should try to recollect which are the conditions where irrespective of CD4 we start. And in few seconds you think over, and then my answer will roll out Just to refresh your memory that it is all patients with TB, those co-infected with hepatitis with severe liver disease, pregnant and breastfeeding women, serodiscordant couple. Most of the people remember these 4 conditions whenever I ask this in the visits, but there is one more condition. Just think of, you could get it, it is all children below 5 years. So we have to remember that we are still at 350, but we have to be updated what is going on in the field with the START trial, Temporano trial. If I take you back to 1996 in Vancouver, Canada, that these protease inhibitors basically were launched, and at that time a slogan was given, hit hard, hit early. Means you start treatment early when patient's immune status is good. Hit hard means you use at least 3 agents. This was a statement by David Ho, who is a scientist in Chinese scientist based in US, that hit hard, hit early. And I don't want to preempt, but Vancouver, again there is a conference in this month itself, and we are moving towards the same thing. With the results from START trial, we are moving again back to hit hard and hit trial early. So that was when to start treatment. Just to recollect, what are the first line AIV regimen we use in the program? We were using different regimen, different combination of zidovudine, stavudine, tenofovir. Stavudine was phased out with lamivudine, efavirenz, nevirapine. But now 2014 the guidelines say use fixed dose combination in a single pill of 3TC, efavirenz and tenofovir. Basically again this was based on evidence from 10 randomized control trial which show that TDF 3TC efavirenz is superior to other efavirenz containing regimen or even with boosted protease inhibitor. I think you are well aware of this. These sessions have been taken earlier also and in the refresher training also, but just for recollection, as of now TDF 3TC efavirenz is the most superior regimen, and again there were systematic reviews which showed that nevirapine is 2 times more likely to be discontinued due to adverse event. And again, to dispel any confusion in the field, basically 3TC and FTC, that is M-triacetamine and lamivudine, are interchangeable. Again, you all remember, you are using it. A single pill is very effective, well tolerated. It's once daily fixed dose combination which can be used for all adults, pregnant women, including, again I say including first trimester, children more than 3 years of age, TB patient, hepatitis B patient. So it simplifies drug procurement, drug logistics, and it is also the preferred drug for people with HIV and TB and HBV co-infection. Again, this is the guidance which was given when we rolled out tenofovir, lamivudine, efavirenz, that all new patients should be initiated on ART irrespective of hemoglobin. All patients on tenofovir, lamivudine, nevirapine and TLE separate pills should be moved to single pill, which has happened because we hardly have single pills now available. Those patients who are on TL plus E due to concomitant ATT will not be changed back to nevirapine. I am pretty sure that these things are happening basically in the field. But there were some apprehensions when we rolled out about side effects of efavirenz. We went to different refresher training review meetings and we got feedback that large number of patients are having side effects to efavirenz. Even those who were on separate pill of tenofovir, lamivudine and efavirenz, when they moved to single pill of TLE, there were some side effects which was probably more related to patient's psychology rather than about a change of drug. So if we really look in last 6 months from different areas, different regional coordinators, different ART center, it has been seen that these side effects are very minimal. Very few patients have been shifted out, and these subside in most patients within 7 to 21 days. So it is very important that we should give adequate time for these side effects to settle down and refrain from changing this regimen in a hurry. Your counselors have to be adequately trained, and MO and other people including pharmacists has to be very clear that patient has to be counseled adequately. I am getting a call that some patients are also developing skin rash. Basically it will depend on the type of rash, degree of the rash. Are you getting a grade 1 or grade 2 rash? And there are already guidelines in place that what to be done in case of grade 1, grade 2 rash, grade 3 or grade 4 rash. If it is a Stevens-Johnson syndrome, basically then you have to very clear that you have to stop this drug. There was another apprehension about the big size of the pill. This can be broken into two. if patient is unable to take, particularly some females complain that they cannot take such a big pill, but they have to be broken into two and taken one after another consecutively at the same time. It should not be broken and taken morning evening. Again, the guideline has to be taken, should be taken with water, preferably 2 hours after dinner, at least during initial 2 to 4 weeks. Those with severe psychiatric symptom should not be initiated, and alcohol naturally has to be avoided. So these guidelines are already in place, and I am pretty sure you are having these guidelines in your. There were some queries about night duties, shift duties. Clarification was given that those on regular night duty should take efavirenz in the morning when they go to sleep after the duty, and those on shift duty should fix one particular time and take on the same time daily. Those who are driving, working on machinery, drivers basically should be advised to be cautious for the side effect, particularly initial 1 to 3 weeks when most of the side effects settle. So there was a FAQ from the field on this. I am getting from JJ 2-year-old child hemoglobin opportunistic ruled out. Basically we'll come to that. That is what I said initially to all centers, that we have these questions from you already with us, and this will come. If I answer this question now, basically this disrupts the flow of the presentation, and it is not related to the issue that we are discussing presently is on efavirenz. So there was a question from the field, how to deal with cases on efavirenz not ready to continue. The patient who say, no, I cannot tolerate at all whatever you say. They have diarrhea, vomiting, vertigo, headache, which is not subsiding even after 2 to 3 weeks. All possible causes ruled out, treat symptomatically, but if condition does not improve, what should be our response? So before I give my answer, basically you have to think again. I said for after every question for a few seconds, what should be your response, and then you know whether your response was in sync with me or not. So if patient is not able to tolerate, we have to change, and we have to substitute with nevirapine. But again, you have to remember programmatic implications, that you have limited quantity of tenofovir lamivudine single pill and nevirapine separate. So only those patients where you have done all counseling and all efforts to ensure that they continue on TLE, only then they can be changed to TLN. For patient, obviously you have got severe psychiatric illness, suicidal ideation, it should not be used at all, and this was earlier circulated as a separate document when TLE was rolled out the first pill. So another question basically which came up from the field was how to adjust the dosage of tenofovir in an adult PLHIV weighing less than 35 kg. This 300 mg dose once daily is for those who have got weight more than 35 kg. So what should be done in such cases? I hope you have got the guidance. I reiterate, basically if your body weight is 17 to 22 kg, it is 150 mg, and if it is 22 to 28, 200 mg. Now you will ask me how to give 200 mg. It is not available as 200 mg. So basically 150 is available if your weight is 17 to 22 kg, but then you have to really look why this is 17 to 20 kg. Is what is the age of the patient and why patient is so emaciated? He has got protein deficiency, protein calorie malnutrition, or what is the reason for such a low weight? So second instructions were given on patient who are already on zidovudine based regimen. It was very clear that they continue on zidovudine, lamivudine, nevirapine twice daily fixed dose combination. But if they are on zidovudine, lamivudine with efavirenz, after completion basically they will continue on the same regimen. Again, after ATT completion, do not change from efavirenz to nevirapine as was the guidance earlier. So just to summarize, our regimen are basically zidovudine, lamivudine, nevirapine or tenofovir, lamivudine, efavirenz, which is the preferred regimen, and again all other regimen basically they remain as such, which were continuing basically with PI based regimen or with stavudine for reasons which we have already discussed in the guidelines. There is a question that you think efavirenz 600 holds good for Indian setup PLHIV. Yes, there is no evidence that Indian PLHIV whose weight is more than 35 kg respond differently to 600 mg. But I would like to say that there are now studies which have come up with efavirenz 400 mg being equally effective to 600 mg, and these studies are under validation with WHO, and there is a likelihood that dose of 400 mg may come, but that is still a issue that is being validated by WHO. Again, serodiscordant couple, because of the prevention benefit of transmission, because the study HPTN 052 very clearly showed in serodiscordant couple that if ART is started on the positive couple, then there is a 96% reduction, which is huge in terms of basically reduction in transmission. So basically serodiscordant couple should also get ART irrespective of CD4 count. Now comes a question which I have been getting. Yes, there is a question, can tenofovir, emtricitabine, efavirenz be substituted to TLE? Yes, I have clarified just now that emtricitabine and lamivudine are basically equivalent. There are a number of studies showing that. So there is no point. These are the same drugs. Tenofovir, lamivudine, efavirenz or tenofovir, emtricitabine, efavirenz combination are the same. Again, Calcutta, you are asking a question on EID discordant, 3 rapid test. You are just out of this. I will go to this when I come to EID, but we are noting your questions which are out of the flow and we will be responding to them today or maybe in the next session. Now this is a very common question that I get on the NASEP, and you must be getting in your SESEP, that what are the ART options for multi-NRTI exposed. I know that you understand what do you mean by multi-NRTI. You had patients historically who were on stavudine based regimen, were doing well, but then came a guidance from WHO and NACO that no, stavudine has got large number of toxic side effects which we may not be able to recognize, like lactic acidosis, or they have got neuropathy. They need to be changed to either to AZT if hemoglobin is good, or to TDF if hemoglobin is less than 9. So these patients basically got exposed to stavudine. Maybe they were then shifted to zidovudine, developed anemia, and were shifted to tenofovir. So they have been exposed to all NRTIs. And in what should be their option if they have been exposed to all NRTIs? What should be their option basically in case they fail? So there are two situations here. One is substitution and one is switch. And I am very sure that you know the difference between two. Substitution is basically for the toxicity when you substitute a single drug within the same group, and switch is basically change of whole regimen to a new regimen when the person is showing signs of treatment failure and the same has been confirmed. So if a person has got a toxicity to one NRTI, that is substitution. So what are the guidelines for substitution for TDF toxicity? If person has got TDF toxicity, he is exposed to D40 or AZT in the past. So what should be our stand? This actually will answer most of your queries that we get from the field. So the guidance on this is basically shift to AZT if person is non-anemic and there is no history of AZT induced anemia in the past. This is very important. Shift to abacavir if anemic. So you have two options if a person has got TDF toxicity. But in case person has got abacavir hypersensitivity, we can also use stavudine as last option. But in such cases, if we shift to stavudine, we should try to build up the hemoglobin, which may be because of HIV per se or because of some other reason. Build up the hemoglobin and shift back to AZT, provided there is no history of AZT induced anemia in the past. Then there could be another scenario for multi-NRTI exposed patient, and you will be getting a lot of these patients in coming months and years. So if patients who are exposed to different NRTIs and then they fail, then you have to change, you have to switch their treatment. And if there is no TDF toxicity, there is no anemia, but the patient is failing, he has not been exposed to AZT, you change to AZT 3TC boosted PI. If there is no TDF toxicity but anemia is there, then basically we will have to shift to D4 3TC lamivudine and boosted PI, and again shift to AZT from D40 as soon as anemia is corrected. Remember, if a person is on TDF, is failing, you have to switch therapy. Basically you cannot use abacavir. Abacavir, as was said, can be used if there is a toxicity and you have to basically substitute. If you have to switch, person is failing to TDF, they will have K65R mutation and your abacavir will not be effective. Third line regimen. Third line regimen, basically now the drugs have been procured, tender has opened, and these drugs will be in place in maybe next 60 days as is the tender requirement. So we will be using darunavir ritonavir combination with reltegravir, and as soon as supply start, this will be rolled out, but this will be only at 10 centers of excellence and 7 Pediatric Center of Excellence. Otherwise, this will not be available at ART Plus centers, and this will have to be finally approved by NSEP. Viral load, you must have been told in your refresher training that now we are moving from CD4 monitoring to viral load monitoring. But again, this viral load monitoring will not be possible immediately, because this requires moving to almost 800,000 tests viral load every year, once in a year for every patient. So basically this will be in a phased manner. But for your information, in 24th of this month, the advertisement has been issued in newspapers, Times of India and other newspapers, seeking expression of interest for viral load on a turnkey basis, that the samples are collected from the site and basically then they are collected by the vendor and then results are supplied by email. This is important what we are going to do in near future. There has been a lot of issues about patients experiencing difficulty in going to CSEP because the distance is too large for them to go. So this mechanism is being simplified. There will be one-time evaluation of the patient after an appointment has been given by CSEP. It will be similar that ART center will have to seek e-appointment from the CSEP. Patient will be evaluated, viral load sample will be taken, and the patient will be sent back to his center, and the center will be informed by ART Plus or the CSEP whether this person is to be started on second line or not, which will be initiated at his parent center. Meaning thereby there will be no transfer in to ART Plus or COE and no transfer out. And basically MND tools will also be simplified if there is no transfer in, transfer out, and your own center will be initiating. This will be a great relief for the patient, and this is being done because now it has been felt that the capacity of some of the centers has been built to identify the side effects of these second line drugs. So this revised mechanism will most likely be effective from 15th of July. And also we are planning to have 100 second line centers. That will be 83 ART Plus centers in addition to 17 centers of excellence. Again, this is new, the HIV-2 guidelines. There are a lot of queries that come on HIV-2 guidelines. These have again been simplified, and what is important basic principle is that ICTC testing should include 2 differentiating kits from 2 different companies, preferably with 2 different immunological principles, and these kits are basically supplied by NACO, so you don't have to do anything, but you have to just look when you get the result that these have been done with 2 differentiating kits and not with the same kit. So samples which are found as HIV-2 reactive, only HIV-2 reactive by 2 differentiating kits, basically these are reported as HIV-2 reactive by ICTC and no further confirmation is required. Samples which are found to be HIV-1 and 2 reactive, basically these will have to go to a referral lab. The patient will visit the referral lab. Patient will actually go to ART center from where sample will be taken and given to referral lab, and the referral lab will does the confirmatory test, and then this will be shared with the ICTC. Again, all these patients will be provided a PI based regimen, and for HIV-2 PI in such cases is lopinavir and not atezanavir. ART guidelines for infants and children. All children less than 5 years should be started on ART regardless of CD4 count. More than 5 years, these are similar as adult guidelines. Again, this is done basically to remove basically CD4 barrier to ensure that all these children remain in care, they are retained in care and are not lost to follow. In addition, when they are in care, basically their other causes of under 5 mortality are also taken care because they are coming to ART center every month. Again, AZT is the preferred in children. Please note it is zidovudine which is the preferred NRTI. Again, if child is anemic, then abacavir is considered as drug of choice for initiation. Stavudine has been phased out. Again, based on available evidence, lopinavir is recommended as preferred drug in all children less than 3 years. So all children less than 3 years should be started on lopinavir, which is now available everywhere. There are comments that slides are moving fast. Yes, these are the slides which actually are already done in the refresher training, Belgaum ART Center. Basically, these have been done, and I was planning to do these slides in 15 minutes, but it's already 35 minutes. So naturally, I want to go to questions faster than this, and you will have the recorded link with you. For children older than 3 years, it will be efavirenz, which will be basically the first component. Again, Basically, why lopinavir ritonavir for children less than 3 years? Because there are two randomized control trial which show basically that there is a reduced risk of discontinuing treatment. Though children show more of diarrhea with ritonavir component, but there is a reduced risk of discontinuing treatment as well as reduced risk of virological failure when we start lopinavir based regimen compared to NRI. And this studies is by Rewari et al. In the Glasgow conference which was presented and has been published after that. So basically, when we talk of up to 3 years, basically it is zidovudine, lamivudine with lopinavir ritonavir. If person is not on concomitant rifampicin containing ATT, it is abacavir, lamivudine, lopinavir ritonavir for all children hemoglobin less than 9 but not on concomitant rifampicin containing ATT. But after 3 years, it is zidovudine, lamivudine with efavirenz. It is not lopinavir ritonavir, and again hemoglobin less than, it is efavirenz basically. Again, this is a very common situation that we see, and we have got some questions also. Again, this question is coming, child is more than 3 years, and this is basically from KGMU Lucknow. Basically, the guidance is if child is more than 3 years or more than 10 kg or 2 NRTI, basically nevirapine, our preferred drug schedule is that we should be using efavirenz based therapy. If the child is on nevirapine, we need to change to basically efavirenz. But again a scenario is child is less than 3 years, less than 10 kg, then basically we have to change nevirapine to lopinavir ritonavir basically by boosting with additional ritonavir, which is called as super boosting to reach 1:1 milligram equivalence, and by this can be done by adding 0.75 ml of ritonavir per ml to lopinavir ritonavir. This guidance is already there in the pediatric component. Or continue with nevirapine if child cannot tolerate lopinavir ritonavir or you do not have facility for super boosting, which may be a real field scenario. Then you continue with nevirapine but adjust the dose to maximum based on the body surface area. Again, this is a question that came from KGMU. It is a situation is age is more than 3 years and weight is more than 10 kg. I think this was what I replied in the earlier also. Okay. So basically if child is more than 3 years, basically this is efavirenz dosage adjustment, and if we see the dosage has been given according to 10 to 15 kg, 15 to 20 kg, 20 to 5 kg, and this is the dosage band that is required for efavirenz when the child is more than 3 years and more than 10 kg. Some special situations are seen in pediatric patient. These are some of the questions that came from field. Basically patient less than 12 years with abacavir toxicity. Do we start D40? Think over what could be your answer. And the answer is basically if there is abacavir hypersensitivity or toxicity, we should use AZT. But if hemoglobin is low, then D40 has to be used. Basically D40 is now not available easily in the program. We are trying to procure some of the basically stavudine based combinations. Tenofovir is another option which has already been approved for children more than 3 years of age. But presently we don't have smaller tenofovir preparations, that is 100 milligram, we don't have availability. So basically we will have to start stavudine in these patients, and the guidance are being sent to all SACs that for such patient where the quantities required are very small, these can be procured locally at the SACs. Again, ART and TB treatment in children on lopinavir ritonavir. Again, basically, because rifampicin alters the metabolism of protease inhibitors, including lopinavir ritonavir, we have to use rifabutin. But children, the rifabutin is not available, and its data on pharmacokinetics therapeutic levels is not easily available. So basically, we do super boosting with ritonavir, for which guidelines have already been sent and are seen in this slide. However, the problems will be basically increased pill burden and possible side effects, particularly diarrhea to ritonavir in children. So what is second line regimen for children? Basically second line regimen is abacavir 3TC with lopinavir ritonavir for all those who are failing on AZT. But if they are already on a lopinavir ritonavir based regimen, presently we don't have another option available to them other than if we can use efavirenz beyond the age of 3 years. For those on abacavir in first line, second line will be AZT, and where AZT cannot be used, again stavudine can be used. So basically these are the pediatric regimen which are already there with you. Alternative regimen in special circumstances, basically infant and children who are less than 3 years who receive TB treatment where nevirapine may not be option because of drug resistance, then in such situation we can use either a higher dose of nevirapine or we can use a triple NRTI which could be AZT, 3TC, abacavir. But this regimen is inferior to a regimen containing 2 NRTI with a higher dose of nevirapine. Okay, the PPDCT guidelines are very clear. I think we are running out of time. Guidelines are very clear. We have adopted option B across the country, lifelong ART, single pill, tenofovir, lamivudine, efavirenz for all HIV positive pregnant and breastfeeding women. This should be very clear, regardless of clinical stage, CD4 count or duration of pregnancy, even including in first trimester pregnancy, including those on efavirenz who become pregnant, there is no need to change. Again, this has to be started immediately without waiting for CD4 count result. That has to be very clear. Again, prophylaxis for HIV exposed infant is based on nevirapine, which you have been using clearly, and the dosage depends on weight less than 2 kgs, 2 to 2.5 kgs and more than 2.5 kgs, which has been simplified to how much you should give. PEP guidelines have been recently revised. You are aware that now these are available for those who are basically the victims of sexual assault, and as a part of overall post-rape care, these should get basically post-exposure prophylaxis as a part in addition to the medications post-pill to prevent pregnancy and all that. Basically now the regimen is tenofovir, lamivudine, efavirenz. Again same single pill, basically for individuals, basically for situation where source HIV patient is ART naive or with unknown status. But be very clear, those who are intolerant to efavirenz again should require a protease based regimen, PI based regimen. And again very important, now as we have got 8 lakh patients on ART, there would be injuries from the patients who are already on ART. So expert guidance should be sought when the source patient is found to be treatment experienced. Again about CPT, again this I think these are some of the last slides on the guidelines. Basically existing guidelines were that start ART about 2 weeks later if the patient can tolerate cotrimoxazole. This was in the very beginning that give CPT for 15 days, C for side effects, because the side effects of nevirapine are also rash and cotrimoxazole is also rash, so we will not be able to clear. But I think now with efavirenz being our basic drug in the first line and not to delay initiation of ART, basically it has been decided in the TRG that ART should be started 5 to 6 days after start of CPT prophylaxis or as soon as CPT is tolerated and patient has completed the preparedness phase of counseling, which is very important part before we initiate ART. HIV TB, basically what is important is slightly different from WHO guidelines. You should be very clear, read this very clearly. ART initiation basically among patient with history of TB, ART to be started irrespective of CD4 count among patient presenting with active TB disease, what WHO says, or those with any past history of TB. So it has to be very clear that any past history, whether this was 5 years back, 10 years back, or whether HIV status at that time was known or not. We get these questions very clearly that okay, this TB was 5 years back. Do I start ART irrespective? Yes, you start. This was before he came to know of his CD4 HIV status, but we know he had TB. Maybe the HIV status was not detected at that time or it was not suspected. So it has to be started. Again, basically rifabutin dose will be 300 mg thrice weekly whenever co-administered with boosted protease inhibitor. Again, there is a new addition to this. Now at 30 high load ART centers, as a pilot from WHO, CTD, NACO, a daily ATT regimen has been started. You get daily antitubercular treatment at these 30 sites, and at these sites rifabutin will also be given daily. These are 30 sites which know this protocol, and once this is expanded to other sites, the guidance and training will be done on this. Again, some guidance that ART initiation should be delayed in some patients, even though they may be eligible for ART, and it should be delayed for 2 to 6 weeks in those patients who are under treatment for cryptococcal meningitis with amphotericin B, or even longer duration if they are not on amphotericin B but are being treated with fluconazole because of non-availability of injection. But one should be very clear, fluconazole is not the drug of choice for treatment of cryptococcal meningitis, it is the injection amphotericin B. Again, CMV retinitis, there is a change. Your present OI guidelines tell you that you use ganciclovir, but now it is said no, oral ganciclovir is the drug of choice because it reduces the cost, it reduces the pill burden on the patient, and only for vision threatening lesions, intravitreal ganciclovir or foscarnet injection plus oral ganciclovir should be used. This replaces the old guidelines on use of oral ganciclovir. This has also been sent in form of OM and basically is available on this also. So, having spent much more time than I anticipated, basically, as was apprehension also that more spent will be spent on the initial slide, but I think this was really required to just refresh, brush up your memories, and we try to answer some of the questions already in these slides on some updates. So let me take up some of the questions in next 15 minutes that we have. These questions are divided into ART first line, second line, pediatric, and then EID and some programmatic questions. Basically, the question is, now again I will be putting up the question, give you 2 seconds time to think answer, and then I will flash the answer. If a patient is started on TDF based regimen first line ART in private sector, should we continue with same regimen? This was an old question when TDF was not our first regimen, so answer is obviously that we continue same regimen. This will not be the scenario now in our country. Again, if patient on TDF based regimen develops nephrotoxicity, ART is stopped in such cases till renal functions become normal. Should these patients be re-challenged with TDF or not? The renal functions have become normal. Shall we re-challenge or not? Okay, I think answer is very obvious. You have to find out the cause of abnormal renal functions, whether this was due to TDF or it was acute insult or there is an underlying renal condition which led to basically the renal toxicity. But if it is confirmed that if TDF is the cause, do not re-challenge with TDF. We need to substitute TDF with abacavir in normal doses. Abacavir does not require a dose reduction in compromised renal states, so we will use abacavir in such cases. But if there are issues with abacavir hypersensitivity, then we can use AZT with dose modification if hemoglobin is more than 9, and if person has got abacavir hypersensitivity, has got anemia also, he has got TDF toxicity also, we have to fall back on our old foe, that is stavudine. But if we have to use dosage of TDF, the guideline is that no dose adjustment of TDF is required patient with mild renal impairment when your creatinine clearance is 50 to 80 ml per minute. In this creatinine clearance, you don't require a dosage adjustment. But what is important is that there should be a routine monitoring of estimated creatinine clearance, serum phosphorus, urine glucose and urine protein, basically to look into whether the person is having Fanconi syndrome. Required details that you require to calculate the creatinine clearance by CG formula is you require patient age in year, which you will have, patient's weight in kg, and patient serum creatinine in milligram per deciliter. So this is the formula which is called as Cockfried-Gault formula or CG formula. This is how do you calculate creatinine clearance basically in males, and for females the whole product needs to be multiplied by 0.85, meaning thereby creatinine clearance has to be calculated. This gives you, I don't think with a glance at this you can remember, this is already in the guidance sent to you, that at what level of creatinine clearance, as I said 50 to 80 you don't require any TDF modification, but if it is less than 50 to 30 and different scenarios, what should be dose of tenofovir, what should be the dose of lamivudine. Efavirenz, we do not require any dose adjustment in case of renal toxicities. Okay, the next question is, patient on Stevens-Johnson syndrome due to nevirapine, should this patient be shifted to efavirenz or put directly on atazanavir? Again, there is nothing to think. The answer is do not shift to efavirenz, do not re-challenge with nevirapine, refer to SESEP only for E approval. You don't have to send the patient, but there should be a photo documentation and you require a E approval to start them on PI based regimen at your own center itself. Next question is, patient is directly started on a lopinavir-ritonavir based regimen by private practitioner and then comes to your ART center, is referred to SESEP, whether we should continue this. Patient is otherwise stable, CD4 count is rising, viral load is not detectable or not available, but CD4. Should this patient be put on our first line? I think the answer is very clear. What do we mean by first line? I say continue PI based regimen, may shift to atazanavir-ritonavir if because lopinavir-ritonavir has got more lipid abnormalities than atazanavir, but this will be first line regimen. So if you recollect, first line regimen is the first regimen that patient starts when he is eligible for ART, and any subsequent regimen which is changed because the patient has failed on his first regimen is the second line regimen. So for this patient it is a first line regimen and this needs to be continued as such. So next question is, patient was diagnosed with 10 toxic epidermal necrolysis with cefixime, cephalosporin was admitted. Now patient is eligible. Should cotrimoxazole be started and shall we give nevirapine efavirenz? Think over. Answer is, patient had 10 with cephalosporin. It is not a contraindication for cotrimoxazole nevirapine because there is no cross reaction of cephalosporins with cotrimoxazole or with. But you have to remember, we do not use nevirapine for new patient anymore. So if this patient is coming for the first time, then we have to start them basically on efavirenz based regimen. Some questions pertaining to second line failure and second line ART. A patient has got immunological failure or immunological and clinical failure with plasma viral load report showing less than 400 copies or target not detected. You repeat again a viral load, again it shows the same situation, meaning thereby he is showing a declining CD4 count but viral load is not detectable. So what is this? First, what you should do? You should look for HIV2. This could be HIV2 or HIV1 and 2 because our viral load that we do is for HIV1 and not for HIV2. Yes, cursor code very good. It could be immunological, virological discordance and it could be HIV2. Very good. I think I am getting many responses on HIV2. But again, go back to your ICTC report. Whether this was because earlier they were they using two differentiating kits? You have to rule out hepatitis B and C co-infection which can also lead to this situation. Again, look at AZT based regimen. If there is overall leukopenia, it could lead to a decline in CD4 count. So you have to see CD4 percentage. So it may be viral load suppressed, it could be a leukopenia which leading to showing a reduced CD4 count. But as it was said earlier that it could be discordance by many people, Chest Hospital Hyderabad, you are very right. It could be discordance also. Another question is atazanavir with hyperbilirubinemia. What do we do? Patient has got jaundice. Basically, he wants to change. I am having jaundice. I basically, people are asking me what has happened to you. But the guidance already given is if patient is asymptomatic, there are no sign and symptoms of hepatic derangement. It is unconjugated hyperbilirubinemia. The enzymes are normal or mildly elevated, not 3 times or 5 times. There is no need to substitute. We can continue for any bilirubin level as long as your liver enzymes are not deranged. Or child book score should be used for patient who has got a compromised liver status. If hyperbilirubinemia is conjugated, then we have to find out what are the causes of conjugated hyperbilirubinemia. It could be drug induced, it could be infective pathology, it could be obstructive, and treat accordingly. Continue with the same regimen. But if unconjugated hyperbilirubinemia is associated with gallstone or renal stone, then you have to substitute basically with a lopinavir-ritonavir based regimen. Question 11. Patient started, this is a real good question, again same, started on ART with ZLN 5 years back, changed to tenofovir lamivudine because of anemia, now on TLE because of the program change. Then patient shows evidence of declining CD4 and viral load is significantly high, right? What should be NRTI backbone? We are talking of a NRTI backbone. Basically, he has been exposed to zidovudine, he has been exposed to tenofovir, CD4 is declining, he has to basically go to second-line regimen. Is the question clear? Okay, let us see. Patient was never on stavudine, so one answer could be can use stavudine and RTI, but we have to remember there are high levels of cross resistance within each class of drugs, and there could be a cross resistance within the NRTI group. There could be two types of basically the mutation that we see is type 1, which are TAMS, and second is TAMS plus M184V, which is because of the lamivudine. So in this case, ideally we should be doing a drug susceptibility test, but that is not available in our country. So basically, in such cases, though the patient is already on tenofovir, basically our answer would be a tenofovir plus 3TC along with AZT. We'll be adding up AZT if there is no history of AZT induced anemia, and along with a backbone of atazanavir ritonavir for such patient. Again, a slightly different situation again with the ZLN, because our patients were on ZLN and now they are being shifted to tenofovir for anemia reasons, not otherwise. So this is a 51-year-old male, started on ZLN in November 2010, developed severe anemia after 4 years. It's very unlikely that you develop anemia after 4 years because of zidivudine. It happens quite early when you start zidivudine based regimen. So first we have to look up basically what is the cause of anemia, but then the patient was exposed to tenofovir based regimen in 2014. Okay, this is 4 years. To September 14, 6 months of TDF exposure, his serum creatinine got elevated, TDF was withheld, and serum creatinine came down, but it is still above the normal. So basically there is history of abacavir hypersensitivity reaction. Patient was started in private sector on reltagravir 3TC atazanavir till, and now patient comes to you, okay, provide me reltagravir 3TC atazanavir ritonavir. So this patient has been exposed to multiple NRTIs, have got adverse event to AZT, anemia, TDF, renal toxicity, hypertension to hypersensitivity to abacavir. But basically if you look, this is more of a hypothetical situation rather than, but we have got it from one of the ART center. So this could be a situation also. But if patient is doing well on integrase inhibitor based regimen, it should be continued, but it is not available in the program and patient cannot buy. So basically we have to start a stavudine based regimen with atazanavir ritonavir, and the dose of stavudine will have to be again adjusted as per creatinine clearance. Okay, coming to the next question. I know I'm a little fast, but you will have these slides with you as a recorded session also. You can review them, and I'm pretty sure most of you who are at least in the program for 1 to 2 years know these answers. What to consider as second line ART in adults previously exposed to zidivudine, developed anemia, exposed to D40, has got neuropathy, pancreatitis, failure to TDF, and again TDF nephrotoxicity. Again, basically we require integrase inhibitor, but it is not available. In this given situation, abacavir can be an option because it says failure on TDF. If failure, then we cannot use, but if it is only a toxicity to basically tenofovir, then abacavir can be used. But if there is a failure to TDF and you cannot use TDF because of nephrotoxicity, still your option remains abacavir or remains a stavudine based regimen. So stavudine was phased out, it was never completely stopped. There is certain situation where you may still require stavudine, but that will actually now require a approval of SASEB because stavudine is not freely available across the country. Okay, again patient with zidivudine exposure was substituted to D40 after he became LFU, hemoglobin was low, and now he is substituted to TDF, he is on TDF based regimen, CD4 count is declining and your viral load is high. Ideally again he should get reltagravir, darunavir, ritonavir based therapy, but in such situation till the time we do not have this, basically if there is no history of AZT induced anemia, basically we can add this AZT to the current regimen. Again a patient initiated on ZLN, see this is important, moderate rash, chain to ZLE, again develops Stevens-Johnson syndrome. You cannot use nevirapine or efavirenz again. Patient prescribed atazanavir ritonavir, again developed rash. Then basically He was initiated on tenofovir lamivudine, atazanavir, but again developed rashes. And skin reference was taken, and it was considered that the rash is basically because of atazanavir, because tenofovir lamivudine was used separately and there was no rash. So this patient has toxicity both to NNRTA, that is nevirapine efavirenz, and ritonavir. Again, patient must be observed for rashes whenever a new regimen is started, and particularly when there is history of Stevens-Johnson syndrome. So this patient was put on tenofovir lamivudine and lopinavir, considering that this toxicity is due to atazanavir, and he is now currently well tolerating his regimen. Again, patient has HIV-2 infection, already on lopinavir PI based regimen, develops immunological failure, then what ART regimen can be given to such patients? There are no validated HIV-2 genotypic or phenotypic resistance assays, and these patients need to be monitored by CD4 count, and option is only reltagravir with darunavir. I think duration of time, I will stop here. I still have almost 40 slides remaining out of this, but I don't want to hurry and saturate your mind also. And we have got some questions now here, and there are some questions pending from the previous this thing. We'll compile these, add the questions that have come up today, and you are free to send email to me or to ITech on this, and we'll get these questions and try to answer each and every question to best of our capability. I thank all those people who have helped me in preparing this. My thanks are due to Dr. Anwar, Dr. Vimlesh, Dr. Guha, largely, and to great extent to Dr. Rajashekharan for his guidance all through, and to all of you who give us this material and have queries in the field. Thank you very much. Thanks a lot, and we meet again on 22nd, and I hope we will have even more attendance. Almost 419 centers have probably logged in. I want all 510 centers should log in next time. Thank you very much. And not in my session, it should be a uniform thing in all the sessions, that basically you should be, because these sessions are prepared after a lot of inputs from everyone, and they give you a concentrated material that particular subject.
Thank you so much, sir. Now I request participant, if they have any question, they can write it down on the chat box. You can see on the right side. E-poll. Now on your left side of the screen, you can see the e-poll. I request you to kindly vote on the e-poll. Thank you, sir. Thank you all for participating in NDLS session. Thank you.